So hello everybody and welcome again. We skipped a week of our hematology hub for the conference, but today we're back to talk about lymphadenopathy. I pronounce it lymphadenopathy. And we're going to go briefly through a little bit more about basics of lymph nodes, the interesting topic of sentinel lymph nodes, which you might or might not have heard about yet. And then we'll go talk through different causes of lymphadenopathy as an overview, and what the different tests are to investigate these really, and talk you through the more advanced testing or the basics of that. So when we are talking about lymph nodes, we have them all over our body. Dogs have them all over the body. It's hard to find a number on how many dogs have or cats. We know that humans are estimated to have 800 or more in your body. So these are not big organs, but they are literally everywhere. And they're quite a well-structured organ. They all quite uniform, definitely at a resting phase. So we'll talk through that in a second. But then these lymph nodes connect with the rest of the lymphatic system, being the spleen, bone marrow, the gals. There's a respiratory system there. So there's lots of other lymphatics that all communicate together and be basically your overview or your surveillance system and your memory system of your immune system, so your antibodies producing cells. Okay. With any organ, if they get larger, they can only get larger because of certain things. Okay, either the number of cells increases or there's something else that gets stored within that lymph node. Okay, so we'll talk through the possibilities here really. But a quick review from the normal lymph nodes. So obviously you've got afferent vessels and efferent vessels. So the afferent bring the blood or the lymphatics, the lymph to the lymph node. It will filter through channels. So it first will go through the cortex, then go through the paracortex, which will then take them through to the medulla. So within the cortex, we find a lot of these germinal centers, which have B cells within them. And this is where if they get in contact with things, they might start proliferating into more follicles and activate. And obviously, if these all proliferate, that whole lymph node will get more swollen, okay, and will enlarge. T cells are more in the paracortex, and then in the medulla, you'll find some T cells, B cells, some macrophages, some plasma cells. And after that, that will all run out in the efferent lymphatic vessel, which will then take it around the body. So when we look at patients with lymphadenopathy, we will split them up in two main groups, really. So in the workup or the differential diagnosis is quite different when we're looking at a patient with a focal lymphadenopathy or a regional, so one lymph nodes or several lymph nodes in one area enlarged, or a more generalized lymphadenopathy. Okay, and that can be, it's rarely one side of the body, say left or right, but either front and or back, but different lymph nodes are all enlarged. Okay, so the focal one often is either the start of a generalized one, or it is more likely a local issue, be it spread of a local tumor, be it a local response to some immune stimulation that could be sterile or could be infectious, could be a foreign body, but it's very much something that is local. And although, say, submandibular and retropharyngeal are very closely aligned, so they might all be affected, that is still regional. There will be more likely something you're going to find in the area that it's draining than going to look all over the body. Okay. Now we'll talk about lymphatic mapping in a second, because that is an interest and a lot of work is being done on that over the last few years. And obviously, when we talk about lymph nodes, it's not only the ones we can feel on the outside. So the easiest ones to feel are your submandibular, your axilla, although they're very difficult to feel when they are normal size, but when they become enlarged, they're a bit more prominent. Popliteal are easy to feel because they're quite superficial. People always talk about inguinal, but definitely if dogs are overweight or have big mammary glands, they're a lot harder to feel. And then the axilla, we can feel in some animals over the rib cages in the axilla area. And then some dogs, interestingly, but definitely, I mean, it's not often we see them, have some lymph nodes just on their, just below their eyes in their face. And we see them because in some dogs they will come up as well with lymphoma, and you get these two little bumps underneath their eyes. But obviously on the inside of the body, chest, abdomen, neck, there's lots of lymph nodes there to reach those very high numbers, similar as in humans, really. So if we look at the causes of generalized or more regional lymphadenomegaly, so we're talking not anymore the focal one, we're not talking the foreign body reaction or potentially the gingivitis, we're talking about a more generalized lymphadenomegaly. The main reason in most areas in the world is lymphoma or leukemia. Even in areas where we get vector-borne diseases, there's still a slightly higher rate of lymphomas than there is of the other causes. But that would come in a close second where you have Leishmania, Lichia, Borrelia, anaplasma in areas where they are more prevalent. That will come a close second. Definitely in the UK, a dog that hasn't travelled, that has generalised lymphadenomegaly and is a middle-aged dog, I would say the vast majority of them will have lymphoma. It is just proving it then, really. So besides the lymphoma and the vector-borne diseases, we're talking about other infection or inflammatory diseases that can become more generalized. So if you have a generalized pruritus or other skin diseases, Demodex, they could have big lymph nodes. If you have a more focal infection, you could get an infection or reactive lymphadenitis, but it's very rare to become more than regional in these patients. But there are some more systemic infections or infections that can become more systemic, and granulomatous is inflammatory there. So we're talking fungal, mycobacteria, and Brucella can do it. So they're always worth remembering. Now, keep in mind, I mean, the presentation of these dogs is slightly different. The more systemic infection dogs are often far more unwell than some of the other, say, definitely than our lymphoma patients. Yes, we have sick lymphoma patients, but most of them with peripheral lymphadenopathy, unless they have extensive internal involvement, so in a later stage, they tend to be relatively well dogs. Okay. Two last reasons there that we're going to group them under is sterile immune-mediated polyarthritis, but it's lymphadenitis, which is a sterile lymph node inflammatory response on aspirates. This can be neutrophilic or necrotic or granulomatous, but you won't see any organisms there. You can't culture anything. So it's very much often a diagnosis of exclusion as well. And as most of the other immune-mediated diseases, this is mainly a younger dog disease. Vast majority of the patients are spaniels, definitely Springer Spaniels in the UK, and these dogs will often present with fever and lethargy as other immune-mediated diseases. Okay. And then what sounds, I mean, through the literature that this is more a UK-based disease, although it's a hard one to believe, is the mineraloid lymphadenitis, where there's mineral deposits within that lymph node that is gradually causing inflammation and stretching of that node, really. I don't see that very often. Maybe you guys pick those up because it's definitely not something that we necessarily see that often. So when we talk about the lymphatic system, and I'm going to talk about dogs, and I've put the pictures of dogs up, although with cats it's a very similar picture. And this is a picture definitely that I got shown during my veterinary education, where we got these regional draining maps of lymph nodes. And these maps were originally designed or described by a person who's called Herman Baun. But this is over 100 years old now. But we still very much, this was the basics I've learned, where it's all draining to. And nobody says that this is wrong, but this was based, I think, on a total of 5 dogs. Okay, so, and these are what we call lymphosomes. Coming back to this, so what people have done is try to investigate, is this still true? And definitely one of the areas where this is becoming more prominent is in oncology, because tumor spreading, a lot of our studies that we report on lymph node metastasis are based on these maps. So we are aspirating what we believe to be the draining lymph node. Now, what people have been investigating is what we now call the sentinel lymph node. So they're trying to find out which lymph node is the actual lymph node where a tumor in the area that you're investigating is draining to. And it looks like, yes, these maps are reliable in probably about 75% of the cases. But in 25% of the patients where people looked at it, and a lot of these are mast cell tumors that they looked at, but other tumors as well, they found that actually the tumor cells or the lymphatics are draining to a different lymph node than what we were previously investigating. So that put a question mark against all the studies that we had from, say, 10, 15 years or older, because if we're not aspirating the right lymph nodes, we might be missing the spread. So what people have developed with different imaging modalities these days is if you inject before surgery, so during the staging or during your investigations, you inject contrast agent, and the contrast agent is slightly different if you use ultrasound versus X-ray or CT. But they put contrast in normally 4 quadrants around the tumor. And then depending on what contrast agent and what modality you use, you're then going to use imaging to find out where is that lymphatic draining to. You can do it similarly during surgery by injecting methylene blue in the area or infrared imaging if you had it. So the picture you would get in picture A, there's a mast cell tumor just above that popliteal area, and they have injected contrast in there. So that's the immediate X-ray that you can see, okay? And it's starting to diffuse into the vessels. Now, the second picture on the right is the X-ray after 24 hours. And you can see that this contrast reagent has been taken up within those inguinal lymph nodes. Because the question could be if this area, well, is it going to spread to the popliteal? Is it going to go to medial iliac? Or are we talking inguinal really? Which allows people to either more sample the right lymph node, or the one that we should be looking at, or going to remove those with mast cell tumors, because that often now is the recommendation if you can. So as we said, I think since these studies have been done, we found out that in up to a quarter of these dogs, tumors are draining to different areas than what we're expecting them to do according to the original mapping, okay? And up to a third of the dogs, the tumor area is spreading to more than one lymph node, which obviously has big implications. Say in humans, we are now going to just removing the lymph nodes that take up the contrast. If we're removing a tumor with its draining lymph nodes rather than taking out all the lymph nodes in an area, because removing all the lymph nodes has a significant morbidity potentially associated with it about swelling and post-surgical problems. So what are we going to do if we get a patient that has one enlarged lymph node? Now, this is a picture of a boxer, obviously, we can all see that, but it has a very large lymph node in its neck, okay? Now, a lot of the things we talked about vet consults and what to get out of them, we spoke about that 2 weeks ago, but it is important your history taken from the owners, because they hopefully have more information that they could give you if you question them, or they might give it to you for free. But say, definitely being in the UK, one of the main questions will be, has this dog traveled before? Where to? Has it had any ticks, potentially? And how long ago? Is the dog unwell? Is there any other lymph nodes enlarged or any other swelling? Does he show any symptoms like coughing, like swallowing issue? I mean, one of the questions, if this was a younger dog, would be, does he play with sticks? Because stick injuries can definitely give you quite marked enlargement, but also a fever and a painful lymph node, really, if there is infection near them. Lymphoma lymph nodes often are not painful, okay? They're not hot, they're not painful, but they can be quite firm and big. And obviously, you're going to go and have a look at the other lymph nodes. Are there any systemic signs reported? So besides lethargy or fever, is there an increased drinking and urinating? Because that will all help you to then define your next steps about bloods and further investigations more towards that lymph node. So I think the first and the main modality, the baseline modality about investigating any lumps, but definitely lymph nodes that are enlarged as well, as cytology. Okay, cytology is a very easy thing to do. It can easily be done in most patients that are conscious, definitely from the peripheral lymph node. I'm not talking the abdominal lymph nodes here, but if you can fixate the lymph node by just holding it, the size of the needles we use are generally the 23 gauge I use. If you go to flow cytometry, you might want to use a slightly bigger needle. But if you think about it, these needles are no bigger than the needles we use for vaccinating or injecting our patients. So it's not more painful, okay? But obviously patient dependent from where we are. When I take an aspirate, I tend to immobilize the lymph node and then try and put the needle into the lymph node, into the center, and redirect it a couple of times. So you are puncturing that lymph node a few times. Now, lymphoma cells, or even just normal lymphocytes or white blood cells, will suction themselves up into that needle. Some people will use suction with a syringe, but then there is the risk of getting some blood contamination, depending how aggressive you are about that suction. Okay, so after you've done that, you want to squirt it out on a slide. Then you take a second slide, put it perpendicular on that first slide, and gradually slide it off. Okay, you don't want to go and lift it up, because if you lift it up, you will fracture all your cells and you will have a non-diagnostic sample. So you don't have to lose a lot of pressure, just gradually lay them together and then slide them slowly off, and that will give you a good sample. Okay, I tend to use both slides. So one of the slides I will keep to use to send off to the lab. The less good slides, where you get just a local smear, really, I'll tend to use for me to go and have a look to see if I have a valid sample and it's not just blood contamination. So, I mean, just to give you a bit of a tip, if you put a needle in a lymph node, generally it will feel quite gritty. Okay, so it almost feels like you're scraping on some sand. And when you squirt it out on a slide, it looks quite, I mean, snotty, for a lack of better word. So quite mucousy. It's not clear mucus. So if you get clear mucus, definitely if you aspirate it around the neck, it could be saliva, but it is whitish, grayish, could have a little bit of blood contamination, but it is quite snotty. So what do I do next? I mean, I will always, if this patient is awake or asleep, I will always go and have a look under the microscope. And these are stained samples, but even with just plain samples, what you want to see under the microscope is, do I have a valid sample, or do I need to go and repeat it? So do I have cells in here? And you'd want to see not only red blood cells, you want to see white blood cells. So they look a bit donut shaped because you do have the nucleus in the center. Is it a monolayer? Because if it's too thick, like the picture on the bottom, nobody can interpret that. I mean, it doesn't matter how good you are, you can't see what's going on in there. And are they not all ruptured? So ruptured cells, if you look here, the ones with the stars, they don't have the nice cytoplasm well demarcated around it. It is very much a ruptured nucleus, and the rest has floated away. Again, very difficult to make a diagnosis on these, really. Or you get this string-like appearance where this has happened, but you then smeared it out all over your smear. Okay. That is my main reason to check it, because I want to know, is this a valid sample, and will somebody else be able to make a diagnosis, hopefully, on this? If it's not a valid sample, you're better off to go and repeat it before the patient goes home, or you wake them up if it needs to be sedated. So you can get more likely a valid sample there, really. If you want to know more, then still on the low power, you're going to look at, is there any interesting areas? For instance, if you have tumor spread, your carcinoma cells will tend to be in sheets spread throughout the round cells. So can you find any of those areas? And that might be easier done after diff quick staining. Okay. If you then still want to know more, you can then go up to the high power times 40 or the times 50 magnification to see, obviously, you already confirmed you've got intact cells anyway. If you then want to see what is the size of my lymphocytes, are they small, intermediate, large? And then what is the proportion of our small lymphocytes versus our large ones? So small ones should be, in a normal lymph node, the vast majority of the lymphocytes should be small lymphocytes. And we're talking 80 to 90%. When it becomes reactive, then the larger lymphocytes or the intermediate will be proportionally get bigger, but we're talking they shouldn't be more than half of all your cells. If they're more than half, and definitely if they're significantly going to 70, 80, 90%, then you're far more likely having lymphoma. Okay. And then what you want to know as well, are there any other cells in there? We're talking metastatic cells, we're talking plasma cells, mast cells potentially. And then the interpretation and the diagnosis. And some of these, if you do it a lot, you can get quite good at it, but I will still always send it to the lab to get a confirmation if you have the time for that. Okay. So if we just summarize that, there's a lot of pros in cytology. There's few, I'm not going to say cons, but limitation probably more likely. But the pros are you can do it in a conscious animal. It will give you a quick result. I mean, definitely with us, once they get to the lab, they can stain it quite quickly. You can have an answer with an external lab, depending on the lab you use, but in 1 to 2 days. It's fairly cheap. It's minimally invasive to the patient. And you can sample several areas within one lymph node or within different lymph nodes at the same time. The cons of it is that the main thing is you do not get that structure picture. And if there's any destruction there, now you don't always need that structure picture. And definitely with the large cell or the high-grade lymphomas, which are the far more common ones in our animals, you won't need that structure. With a small cell lymphoma, potentially it would be a difficult one to diagnose on cytology. Because as we said, if 80 to 90% of your cells are going to be small cells anyway, well, if it's 95%, did you just aspirate in that area? What are you talking about? So that might be a hard one to interpret. You won't get a mitotic rate either. But in lymphomas, we often know if they're large cells, they're going to be high-grade cells mainly. And I'm not sure I've written there. Always take more than, oh yeah, I think always take more than one sample if you're going to aspirate it of a lymph node. Take 2 or 3 of the lymph nodes that are enlarged because it's more likely that people will give you a more reliable answer. Okay, and then the main question comes with a lot of people come to us, but what do we do next? Cytology has given us a questionable result. So with that, I don't mean that it says it's a non-diagnostic sample, because if it's a non-diagnostic sample, the question is, well, can we get a diagnostic sample? Or is it that difficult to get hold of this lymph node? At which point it might not be worth repeating it. But if it is because the dog was wriggly or it is aggressive, then can we get a better sample by giving it some trazodone or gabapentin before? And can we get a sufficient sample? Okay. If that's not possible, what are your next steps? I'm first going to mention histology here, but histology is probably less common these days than the other tests we're going to talk about. And it depends a little bit what you're going to try and achieve. But obviously, histology, we can do either an excisional or an incisional biopsy, or if the lymph nodes are big enough, we can do a true cut biopsy. Okay. That will allow us to look at the tissue anatomy and the structure. We'll get a large area to consider what is going on, and it will give us a mitotic rate. But the big downsides of histology is generally it's not cheap because we need an anesthetic or sedation. It needs more fixation, so it will take longer to give an answer. So even if we end up resorting to histology, one of the tips I'm going to give you is do an impression smear of your histology part. If it's a true cut, do a rolling smear over a slide. If it's a wedge or a lymph node, I mean, if it's a whole lymph node, cut it in 2 and do an impression smear. And if you're in a rush, if you send that off to the lab first for cytology together with your histology, you'll probably get your results of your cytology without even needing the histology in the end. And you'll get it quicker. It's still nice then to see that the histology confirms it, but if you want a quicker answer, that's an option. And obviously, I think if we do a surgery and if we want to treat this dog for lymphoma, because that's what we found, for instance, then you might have to wait a little while because that wound needs to heal up a bit before we're going to give it chemo, as that's going to suppress our immune system and potentially increase the risk of getting an infection maybe. Okay, as I said to you just 2 minutes ago, we don't that often do histology anymore. So the 3 extra tests that are quickly going to update you guys on, that definitely we can do in the UK quite commercially. I'm not sure abroad how easy it is to get all of them, but it's immunocytochemistry, PAR testing, and flow cytometry. And they each have their own benefits to it and their own limitation. So immunocytochemistry can be done on a plain smear of the cytology, and they're using similar dyes as they would do with the immunohistochemistry. So if we got a metastatic tumor, we can use this to find out what tumor it is. If we got a lymphoma, we can try and figure out if it's B or T cells. So what happens is they take the slides, they stain them for B, they stain them for T, and figure out. Now, this does not confirm lymphoma. So what you want to know first is this is lymphoma. This is a cancer form. And then we're going to stain them. Because you're still going to get areas, you're going to have more B cells or T cells. This is not confirmation that this is cancer. But if you get all the same in a good sample that says it's a tumor, you can define if that is a B or T cell. So that's in contrast with what we call PAR testing. So PAR testing, the letters stand for PCR, for antigen receptor rearrangement. So PCR is DNA testing physically. And when we're talking about B and T cells, and taking you back to your immunology lectures, maybe a few years, we know that there's constant regions in your B and your T cell receptors that every cell will have. But then there's the variable regions on the top, which will be different because it'll be a different combination, and it'll be different for every B cell. We'll have a different type of variable region, and it will be different. The antigen binding site for T cell will be slightly different. And what we can do is we can put these through a test that will look for the DNA of these cells. And the principle very much is if you have a neoplastic clone of cells, so a neoplastic form of if you have lymphoma, then they will all originate from this one cell. So if it's T cell lymphoma, they'll all originate from this one T cell that has this one variable area, but they will all have the same variable area. And by definition, with a reactive one, you should have a monoclonal form. So they will be more T cells, but they will all have a different variable area. Okay. You can get some false positives, and one of the diseases that can give you false positives is leishmania. So when do we consider doing a PAR test? I think when our cytology and our histology leaves a question mark if this could be lymphoma or reactive, then a PAR test can help you. You need to remember that there is a fair proportion of false negatives, definitely in cats. So you might still get a negative result and it might still be lymphoma. Okay. If you know what your genetic profile is of the lymphoma you're dealing with, in theory, you can use this to then check if you've got any minimal residual disease within that lymph node once the lymph nodes are normal. Okay. I'm not sure anybody's offering that commercially for the moment, but in theory, as long as you have that genetic profile of your patient's kind of lymphoma, they can recheck for that and see if that's still present. It is not helpful to do immunophenotyping if you can get either immunocytochemistry or flow cytometry. Okay, it's not helpful to stage your lymphoma, and it's not a good procedure to do screening in a healthy animal. So you need to select when you're going to use it. Otherwise, it might be difficult to interpret your results. So you will be extrapolating results that are not necessarily what you can get from your PAR test. So the last one to briefly talk about for our last 5 minutes is flow cytometry. So when do we consider flow cytometry? Here we go. I mean, I put these two in the wrong direction. So flow cytometry is based on using live cells, and that's quite essential. We need living cells to do flow cytometry. Okay, so what we need to do is we need to either get an FNA from a lymph node and we flush it out, and any lab you're going to use for flow cytometry will either provide you with transport medium, depending how long it is for, or will tell you how to dilute EDTA and EDTA serum of the same dog and use that as the medium to keep the cells alive. And then you flush your FNA out into this medium to try and keep it alive. So one of the things as well, do not do this on a Friday afternoon. By Monday, it is less likely there's sufficient number of cells alive. So we would always get it in an overnight courier, and we would always ring the lab and just make sure that the machine hasn't suddenly broken down and our sample's going to go to waste. Okay, so what they do is very similar as the staining on the slide with immunocytochemistry, is they're going to stain our sample and the cells in our sample with different fluorescent antibodies. And then they're going to filter that through a laser light, which, depending on how the light diverges, they're going to decide on which one is positive for this marker, how many, what proportion are we talking about. And definitely if we're talking about a lymphoma, we're going to be able to tell what markers these cells are positive for. And that isn't just a B or a T cell marker, okay? We can use leukemia markers on these. We can use other markers on there where we start to know that certain markers will give us, on average, a better prognosis for treatment or worse prognosis. This is the one situation that I would then aspirate with a 21 gauge needle rather than a 23 gauge needle, because you're more likely to have a good sample. Okay, with a 23 gauge needle, I think it's about 40% of the cells or of the samples that are non-diagnostic. So when are we going to use flow cytometry? Again, we're going to want to immunophenotype. We know, I mean, it's lymphoma. We want to confirm it's lymphoma because it's a monoclonal bit. They all have the same marker. And when we talk, is this lymphoma, stage 5 lymphoma, or are we talking this is lymphoid leukemia? Because then they will have certain markers that come from the bone marrow cells either being absent if it's a mature lymphoma and being present if it's a leukemia. Okay, so we said there's certain markers we can use for prognostic markers in lymphoma, and we can distinguish between a reactive process and a neoplastic process, because in a reactive process, you will always get other different lymphocytes there. You can differentiate between myeloid and lymphoid leukemia. And the one place that I definitely come to its right as well is mediastinal masses. Definitely when we're talking the main two sources of mediastinal masses are thymoma or lymphoma. The thymoma can be quite lymphoid rich. So even on a normal aspect, you might get quite a lot of lymphocytes in your thymoma. And in the lymphoma, you could get some epithelial cells in it because you are talking this is a thymus and there will be some epithelial cells in it. And it often is the proportion, but flow cytometry will help us to find out which one of these is neoplastic. So I think that is me talking about more advanced testing and what you can do to get to the bottom of enlarged lymph nodes, really. Before I take any questions, just wanted to let you guys know, for the people that didn't yet, that we're going to start a anemia course at the end of this month. There'll be 4 2-hour sessions, which will comprise of a lecture and then some time set aside for question and answers or case discussion. So if any of you are interested, these are the links. I'm going to leave those up, but I'm going to, although I can't really leave them up. And then next week, we're going to be talking about IMHA and a brief overview. Obviously, I can't discuss everything on IMHA in half an hour, but we can give a brief overview what the current recommendations are. So I'm going to go back to the room now, really, and see if there's anybody who would have any questions or wants to discuss anything. Then please feel free to unmute yourself and share with us what you would like to ask me. Everybody's gone very quiet. I can't see anybody either, but okay, yeah, otherwise put it in the chat, sorry. I know some of you will be able to talk. Who's talking?
It's me, Ayub.
Ayub, are you right?
Yeah, I didn't ask for your permit actually, so I thought like I can pop up and ask my question.
Yeah, go for it, and then I'll do the one that I see. There's one in the chat as well, but you go first.
Yeah, you just talked about it already. I mean, like the patient is not okay with the more diagnostic test. Like you can only do the cytology, and what I struggle is like the dog is obvious, you know, the obesity, and you can't kind of find the lymph nodes, especially poppitals. And what is your approach? Like, how do you make it useful to take your FNAs? Like, you can
Say that
can
again. You
locate
can't do
them.
the
You can locate
cytology.
them.
You can do the
Yeah, yeah,
cytology.
yeah, yeah. You can locate them. You can even do your aspiration, but it's not that good cellular. It's not that proper, and laboratory just tells you like it's not good in cellularity. Please do it again, and you do it again and again and again. And the owner is not okay with surgery, and I mean, like, you can cut off the lymph node for histology, you know. So what do you do?
Okay. I think the one thing I would tell you is, I mean, give your lab a ring and ask them why it's not diagnostic, because it can be
Hmm.
either because your smears are too thick, because your cells are lysed, because you don't have enough cells and too much contamination of blood, or it could be just that they haven't been dried properly after you've taken them. And that's a very easy one to change
Yeah,
because then we need to get better at drying our smears. And that has happened. I mean, even when I look at what the surgeons get, they say is non-diagnostic, although they're good samples. But if they haven't been dried properly, then these cells won't necessarily be in a good condition when they arrive to the lab to be then stained, and it will be a struggle for them to get the answers. Um, Otherwise, I would say, yeah, I mean, definitely if the lymph node is big enough and you feel like you're going in it, then it is a matter of your technique of smearing it. And my recommendation would be, I mean, if you do it, I don't know how the situation is where you guys are, but if you practice it after you put a dog to sleep and just do it and look under the microscope, even if they're unstained, if you can see plenty of cells that are intact in a monolayer, then somebody else will be able to give you an answer.
okay.
Otherwise, I mean, yeah, I think often it is technique and it's something in those steps that you'll have to change. But I would ask the lab about can they tell you why it's non-diagnostic? Because there might be a clue there that you hadn't even thought about and that you can easily change.
Yeah, sure. So how do you make sure, like, when you do aspirates, like, I mean, when you're going to do it, you have to make sure you're doing to locate the lymph node, and you have to do it from the cortex. I mean, you shouldn't just insert your needle into the medulla. It's better to be
Go through the
cortically
cortex. Yeah.
placed. So like young dogs or fat dogs, how do you make sure you're going to do it? Yeah.
I mean, depending
I
how
don't
big the
want,
lymph node is,
yeah,
I think I would always try and immobilize them as good as you can. I
yeah,
mean, and definitely the poppy tail is quite good because you can generally grab it from both sides. It is not unusual to have some fat around that. That's the one limitation in fat dogs. They are a lot harder to feel, and the fat is often in a bit of pockets there. The only other thing you can try if you can't feel it, well, if you can't feel it properly, I would question you and say, well, why are we worried about it? Are there other lymph nodes up? But again, in a fat dog, they might be equally as hard. If
yeah,
it's still the one lymph node that you want, because that is where the tumor will be draining to, then the only other way of doing it, bar removing them, but as you said, can't do that, is doing
yeah.
ultrasound guided.
Oh, yeah. You need like guiding with ultrasound to just insert the syringe needle into the cortex and just to make an aspiration. Yeah, yeah.
Yeah,
That's a
through
good.
the cortex. I tend to estimate, I mean, depending how big the lymph node is, you go through the cortex into the center and you go back in and out. I don't go completely out of the skin or out of the lymph node, but you move them around a couple of times. But you go to the cortex, and often with reaching the cortex in the bigger lymph nodes, there's quite a bit of tension around that. It's almost like you pop, I'm not going to say a balloon because obviously it doesn't pop, but you can feel a bit of pressure giving away.
Yeah,
And then you'll often feel this gritty feeling when you go through the medulla to try and get some samples. I very rarely suction it. If I really don't get anything, then I might try it with suction, but I
yeah,
often don't find that I get much better samples from it. With a lymph node, we're not talking sarcomas here, but yeah.
yeah. Of course. Thank you.
Okay.
Thank you. Yeah,
Sorry. Is that sufficient?
yeah. It was good. Yeah. Yeah, I know. Yeah, it's just about a technique and just getting some help from the paraclinic there, like ultrasound. Like, I mean, trying to convince maybe the owner just like please help me. I want to do something more. Yeah, I need something more.
Yeah, I know, but I mean, it is a test as any other. Sometimes they are non-diagnostic, and that is unfortunately the
Yeah.
nature with any testing in anything in life, not just vet medicine.
Yeah. For us.
Um, David, you asked me how do I manage clients' expectation when facing lymphadenopathies? What kind of expectations are we talking about? I'm sorry, but I'm not sure I understand. Is it about the post-surgical swelling? Is it why are we doing it? Um, can you give me a little bit more? What kind of expectations are we talking about? Because generally, when I need to, if we're talking about removing a lymph node, I would explain to them why it's important. And definitely now with mast cell tumors, we know that as a therapeutic focus, if there's early metastatic disease, and I'm talking early metastatic disease here, with an intermediate grade, that often it will stop at the lymph node for a long, long time. So if you can remove the lymph node, there doesn't seem to be any benefit of then adding chemo to it. So I think I explain to the people removing the lymph node, if it's about a tumor, is a therapeutic and a diagnostic procedure, which will help them for future planning. If it's about a lymph node that we're questioning, is it lymphoma? Is it reactive? Um, I just explained to them that it will be very hard to get a diagnosis. In those rare cases, it'll be very hard to get a diagnosis without taking a lymph node out. Expectations when there is finding and a possibility of start doing the workup. Well, I would still always say we'll aspirate it first. And again, I mean, take into considerations that I work in referral, so the people have already gone probably through the stages that you're talking about. But we would generally try and aspirate it first, unless there's a clear reason not to. If we can't have the answer with that, and I'll explain that to them, it's worth doing it, but I will give you the answer in about 3/4 of the cases. If we don't get the answer, depending how unwell the dog is, we can wait for a week if it's not very enlarged and see what it does, and otherwise repeat the aspirate, or we can try and true cut it or remove it. But that's where I think a lot of these, we don't have to remove the lymph node anymore, unless, as we're speaking, mast cell tumors. We can do some other tests on them where we don't have to put them through the general anesthetic. And although none of these tests are cheap, they generally are cheaper than having to anesthetize a patient and take a lymph node out, and then the complications potentially or the swelling associated with that. I'm not sure that answers your question. Okay, perfect. Thank you. Thank you, David. Any other questions, people? No. Okay, David. Also, apart from the cases where there's markedly enlarged lymph nodes, is there a reference to know how much an increase should start concern us? No, I don't think there is a reference. It depends a little bit what's going on in the patients and what you're suspicious of. I would, and it's a very subjective finding. I was in two minds of telling you guys this. If you feel enough lymph nodes, then generally I would say reactive lymph nodes can get double in size, but even with some skin diseases, more than double in size. But they often will stay quite rubbery and squidgy. Carcinoma, lymphoma, lymph nodes, they will often go hard before they get larger. And I don't have an explanation for that, but they often will be very firm. So normal lymph nodes, I would say, feel a bit like a jelly bean. Reactive lymph nodes feel similar, maybe a bit firmer, but still a bit rubbery. Metastatic lymph nodes are often, I'm not going to say golf ball hard, but solidly hard and easy to find the margins around it. Reactive lymph node or infectious lymph node often have a lot of edema around it as well. But I don't think there's a cutoff. We've seen dogs with crease caps that were 4 or 5 centimeters, but that have systemic skin disease, and they are still is because of the skin disease. But you should always relate it to the amount of disease being present. If they got one tiny pimple, that is not going to give them a massive lymph node. Okay, so if you have lots of Demodex, you will get big lymph nodes and systemically enlarged lymph nodes within that peripheral area. Okay, so I hope that answers your questions, people. Hopefully I'll see some of you guys next week or on the course later on this month. If you got any ideas that topics you want to discuss in a following talk, drop us an email or post it on LinkedIn or connect it one way or another towards us, and we will see what we can do. Thank you. Have a good day.